cognitive deterioration in Parkinson's disease. Perhaps deterioration is not my favorite word. I prefer impairment, but more or less we all know there are different cartoons as how is the course of Parkinson's disease and how it progresses from non-motor symptoms or that are prodromic, some of them of the disease, to more advanced phases. And I have drawn this triangle just showing that cognitive impairment is a central feature of Parkinson's disease, nowadays acknowledged as Parkinson has its own cognitive impairment and perhaps it's a dementing illness. And all things that go to worse begin by little impairment. But what we know now is that cognitive impairment in PD is present from the very early stages, even in patients that still have no motor symptoms. And many times these cognitive deficits are not clinically apparent, and then you need a formal neuropsychological examination to put in evidence that the patient has some impairment. And when we are going to talk about some tools and some tests to use just to recognize this cognitive impairment, but it's important to know that many times what you are seeing depends on which is the instrument that you are using to see the problem. And then even in non-demented patients with Parkinson's disease, cognitive impairment is a problem because everyday tasks place a huge demand overall on the executive system, and you need sequencing ability, planning, organization for everything that you make in an active life. You need it for shopping, for preparing meals, for handling finances. And then these executive dysfunctions heavily impact ADLs in Parkinson's disease, and it implies that if you have this impairment, you are going to lose independence as the cognitive impairment progresses. And then cognitive impairment also impacts attention, short-term memory, verbal fluency, and this leads to communication difficulties. That is, even if you don't work or you don't organize meals, you have to communicate, and when you have this kind of fluency problems, for instance, that is not always isolated, because it is important to acknowledge that cognitive impairment does not occur in isolation in PD. It combines with apathy, with depression, with anxiety, as we have heard in the previous lecture. But patients with Parkinson's disease and cognitive impairment have a greater disability, poorer survival, and increased likelihood of institutionalization. And then improving the recognition of the period of this preclinical disability will enable better timing of therapies to delay the onset of disability. What are the tests or the functions that are impaired in this cognitive deterioration in Parkinson's disease? For instance, one very frequent is verbal fluency. You can examine verbal fluency from different kind of tests, but phonemic or semantic, they are exploring two different kinds of functions. For instance, phonemic fluency is exploring mainly frontal functions, but if you explore semantic, that is, for instance, name of animals, objects in the supermarket, you are also exploring the temporal lobe. And then you can, by exploring semantic and phonetic fluency, you can explore both the frontal and the temporal lobe. But here I put alternating fluency is very, very specific for executive dysfunction, and this is a really interesting way to explore verbal fluency in non-demented patients, that is to alternate, for instance, an object of the supermarket and another category that is different for this. Speech fluency is impaired in Parkinson's disease. They have many patients complain of this tip of the tongue phenomenon. Sustained attention is very, very classic impairment in Parkinson's disease. Working memory depends on the dorsolateral prefrontal cortex and on your level of dopamine innervation. The backward digit span is a useful test to explore working memory. Set shifting, set acquisition, and conceptualization are functions that you can explore by simple tests such as the trail making or the Wisconsin car sorting test or some task of towers. Cognitive processing speed, that is, in the ancient days, cognitive impairment of non-demented patients was called bradyphrenia. That is, your speed of cognition is slowed. And for instance, digit symbol is a nice test to explore. And then all of these, free recall, verbal and visual memory, unprompted clock or figure drawing, and a classic function that is impaired not only is executive dysfunction, but also from very early phases in PD, visuospatial or visuospatial skills such as mental figure rotation or line orientation can be impaired. All these are functions that mainly depend on the integrity of the frontal function and also depend on the integrity of dopamine innervation. That is, it is not exceptional that they are impaired from the early periods of Parkinson's disease. But as the disease progresses, there are some patients that also have problems with semantic verbal fluency, with naming, such as with the Boston naming test, with not only with recall memory, but with recognition memory that depends more on the temporal lobe, or they have not only problems in spontaneous drawing of a clock, but they have problems in copying a clock or a figure. And then these are more posterior cortical functions that depends more on the parietal, on the temporal lobe, and they are classic from patients that are demented in Parkinson's disease. That is, I'm going to propose you based on many available papers, that there is a change in the pattern of neuropsychological deficits along the progression of cognitive impairment. And it can be seen, for instance, using this scale that separates a score for frontal executive functions and more posterior cortical functions. You can say that two classic tests, that is, for instance, the alternating verbal fluency and the working memory, shows an early and progressive decrease in the performance of this task, going from cognitively intact patients, mild cognitive impairment, and demented patients. That is, all these items, sustained attention, working memory, alternating and action, verbal fluency, and clock drawing, progressively deteriorates, and you are not going to see an abrupt change. But if you explore more posterior cortical functions, such as the copy of the clock or naming, then you can see that there is an abrupt change from mild cognitive impairment to dementia. That is, over the executive deficit that is progressive, there is a superimposed deficit in posterior cortical functions, and these characterize the transition to dementia. That is, dementia in Parkinson's disease can be characterized by this addition of more Alzheimer's type defects upon this executive predominant problem. And you can see it in some longitudinal studies, such as this, as the campaign study, showing that besides age, that is very important predictor for cognitive impairment in Parkinson's disease, those neuropsychological tasks that are more posterior cortical, such as semantic fluency and inability to copy, are the ones that predict dementia at the long run. But phonemic fluency and other frontally based tasks were not associated with dementia risk in this study. If you examine these from, for instance, from a neuroimaging point of view, you can see, for instance, that you have in patients that are drug-naive patients that there is a cortical hypometabolism from the earliest stages that is independent of therapy and of motor disability, and that the early impairment of the more posterior cortical region, that is a pattern shared from the early stages to the mild cognitive impairment, characterize or are more typical and perhaps an early marker of the progression to dementia. And the same can be seen in other studies. For instance, this is one for our group showing that cortical thinning in temporoparietal regions are typical from the stage of mild cognitive impairment to dementia. That is, this is a posterior cortical impairment added to the frontal dysexecutive problems. And also this very recent paper from the iCycle study showing that an extension of cortical thinning in the temporoparietal regions in addition to frontal atrophy characterize people with mild cognitive impairment in Parkinson's disease. And there are a nice number of papers showing that, yes, mild cognitive impairment is a risk factor to dementia in people with Parkinson's disease. This is a nice paper from my friend Maricruz Rodriguez-Oroz, and they also showed that there is a posterior parieto-occipital hypometabolism that may differentiate mild cognitive impairment from dementia in Parkinson's disease. This is, we can observe this same problem from different point of view, from different authors, from different techniques. But interestingly, they followed up these patients and they say, okay, cognitive impairment is a two-step process. And first, there is the same as we can observe from a clinical point of view. There is a progressive dysfunction of prefrontal lobe, of prefrontal regions and temporoparietal regions. That is a functional problem, but over this functional problem, there is an added hypometabolism and atrophy of the hippocampus and the middle temporal lobe. That is, we go from a relatively subtle cognitive impairment in Parkinson's disease, where you have visual, perceptual, and attentional dysexecutive dysfunction, mainly explained by dopaminergic deficits and relatively subtle pathology, to a visual, perceptual, and attentional executive dementia, in which there may be a crucial contribution of non-dopaminergic systems and perhaps of advanced pathological changes. And which are these changes? We can examine these changes either from a structural or from a neurotransmitter point of view. From the structural point of view, you all know that limbic and neocortical Lewy bodies and synaptic and neuronal loss implies that your cognitive integrity is no more running. And added to this, we can observe from different papers that there are a contribution of AD-like changes such as amyloid plaques or cerebrovascular disease and also neuroinflammation. And you not need the neurons to degenerate absolutely to have this function, because the alpha-synuclein deposition is already associated with a significant neuronal dysfunction in the absence of frank neuronal loss in Parkinson's disease. That is, first you have dysfunction, and second, you have a neurodegeneration. That is, which are the ones that are more important? For going to dementia, you have to have a significant dysfunction both in dopaminergic pathways and in cortical cholinergic pathways that occurs also before having a frank neuronal degeneration. And thereafter, there is a widespread degeneration of both cortical and cholinergic pathways. And interestingly, these are not independent, but they are synergistic. And there are some nice papers that show this. But which are the evidence for this? For instance, this is a nice paper of the neuropathological substrates of PD dementia, showing that you need to have cortical Lewy bodies for dementia to develop, but often it is not only the exclusive cause, and also you have changes more typical of Alzheimer's disease. This is a paper. The cartoon is from a paper of Glenda Halliday showing that there are different ways to become demented in Parkinson's disease. One is following the classic steps of Braak and Braak, and perhaps the black line represents dementia. In this typical case, you have Parkinson's disease for more than 20, 25 years, and then you become demented as the pathology aggregates and the progression goes to the sixth stage of Braak, and you have all the cortex, plenty of alpha-synuclein. But you can also have a different course. If you begin your disease at 70 years, for instance, then you have more probability to have more Alzheimer's disease type lesions, and in 5 years you are going to develop dementia. And still, there are a third type of patients that develop very early dementia, and perhaps these are the ones that we classify as DLB patients, and we cannot make this administrative separation between PDD and dementia with Lewy bodies. This is another interesting paper showing that you can predict dementia in Parkinson's disease, looking to cortical Lewy bodies, but looking also to Alzheimer's disease changes. And many patients, you can classify them, in spite that they are typical PD patients, of having the changes that are required for classifying them as Alzheimer's disease patients. But the ROC curves show that the best predictor is when you put together the alpha-synuclein and also the Alzheimer's disease changes, and this is the one that is showed in red. That is, perhaps cortical amyloid beta and age at disease onset seem to determine the rate to dementia, and the older you are, the worse it is. This is another very nice paper and recent paper showing that you need two things to develop dementia. First, you have to have dopaminergic degeneration, but not only dopaminergic degeneration in the nigrostriatal pathway. You also need, for dementia to appear, to have degeneration in the A10 lateral UPTA loss, and then in the mesolimbic and mesocortical pathway, added to cholinergic defects. From the very beginning, patients with Parkinson's disease have cortical cholinergic deficiency. But what makes the difference is not the cortical cholinergic deficiency added to the dopaminergic lesions, but you need to have hippocampus cholinergic deficiency. And then if you have this CH4 neuron loss, then it is very nice to classify patients with dementia and to separate from patients that are not demented. And then it gives us another perspective of what happens with the neurotransmission and what happens with the lesions. And of course, we can explain some of the exploratory findings in the neuropsychological test going to the neurotransmitter model. And you all know that dopamine has a major role in modulation of attention, working memory, and executive function. And if you have a deficit, or a dopaminergic deficit, as it occurs early in the course of Parkinson's disease, you have a loss of amplification of cortically initiated signals, and the patient behaves as they have always doing a second task demand, and they are also slow in their mental processing. But acetylcholine has also a major role in modulation of attention, arousal, sensory processing, and memory. And then cholinergic deficit profoundly affects many cellular processes that at the final end are the same that are regulated by the frontal lobe. And then both add to give the typical picture of a patient with failures in the performance of neuropsychological tests. Perhaps the tests that are more depending on posterior cortical function behaves as the kidney function, in the sense that you don't observe an abrupt failure since you have lost 80% of your kidneys. But there is a progressive lowering of brain acetylcholine levels that, of course, are more related to the degree of cognitive impairment than to the years of evolution of Parkinson's disease. And if we put all this together in a cartoon, dopamine is partially responsible for this executive syndrome. Noradrenaline contribute to attention and mood, serotonin to depressive mood, and of course, cholinergic deficiency explain more posterior cortical functions such as language, memory, and visospatial. But the boundaries between these systems are not well defined. Which is the prevalence and risk factors for cognitive impairment? Between 25% and 50% of patients with PD are going to develop mild cognitive impairment or dementia within 5 years of diagnosis. This is an impressive figure. Could we predict those at risk? Is cognitive impairment a continuous or a dichotomic process, in the sense that, posterior cortical deficits appear only in a subset of patients and only in a given period of time? Here you can see that this is a paper taking subjects at risk for Parkinson's disease. They still not have a definition of brain bank criteria for Parkinson's disease, are only subjects with hyposmia, but with DAT-scan dopaminergic deficits, and these subjects also exhibit changes in global cognitive abilities when you compare with a sample of normal controls, and specifically they have executive function and working memory problems. That is, from the very beginning of the Parkinson's disease, you have this problem. But if you observe this, that is a nice paper from Doug Arsland, at least 1/3 of patients at the very long run show cognitive stability according to the Mini-Mental, that perhaps is not the perfect test to examine cognitive functions in PD. But perhaps they are patients with different trajectories of mild cognitive impairment. This is a very recent paper from the group of Diane Weintraub, and they show, this is a longitudinal study, there are not very much longitudinal studies, and interestingly, they show that almost 50% of PD patients with normal cognition at the beginning develop cognitive impairment within 6 years of baseline visits, and that patients newly diagnosed with mild cognitive impairment progress to dementia within 5 years. Then it seems that nothing to do, and this is a dementing illness, but perhaps there are more things to comment on this. The problem with this study is that they are not incident cases, but are prevalent cases, and perhaps we can discuss about this. But what was important in predicting cognitive impairment were male sex, increasing motor problems, longer duration of PD, presence of depression, and lower baseline total MATIS. This is important, and importantly, in this paper, age was not a risk factor. It is explained in the paper why not, because in many other papers, age is the main problem driven to cognitive impairment in Parkinson's disease. But we can say that deficits in memory, visospatial ability, attention executive, and some demographic predictors, among them age is one of the more important, drive you to cognitive impairment. But can we define more risk factors at baseline, just trying to separate subsets of patients? Of course, GBA gene is a very important issue here. Those patients that have GBA mutations have more probability and very more probabilities to have cognitive impairment. And also there are some polymorphisms within the GBA gene, and this is a very interesting paper, that are associated even with lower performance on very specific tasks such as working memory and executive function. ApoE4 was controverted whether it was or not a risk factor, but nowadays it is associated with lower performance, mainly on more posterior cortical functions, semantic verbal fluency and word listing. And of course there are some other papers showing this, but interestingly, those patients who are LRRK2 positive show higher global cognition and lower prevalence of dementia, and at least we can separate two extremes, putting on one side LRRK2 and the other one GBA. Are we going to perform a lumbar puncture in all our patients with Parkinson's disease? Okay, some markers of Alzheimer's disease show increased risk in PD also. And if you have a lower A-beta 42, you have a risk of dementia in only 2 years, according to this. Many interesting studies have combined neuroimaging and biofluid markers, and for instance, elevated total tau protein and decreased AB142 level correlate with reduced gray matter volume, comparing demented and non-demented patients, and a combination of these A-beta 42 and cortical thickness is significantly associated with progression to dementia, and also high level of total alpha-synuclein correlate to posterior cortical thinning in Parkinson's disease. That is, you have more risk factors to go to this clinical picture of posterior cortical impairment. However, the utility in the single patient of these techniques is nowadays is limited, because you cannot, aside from research studies, use it in the individual patients yet, but perhaps it is coming. As well, you don't use neuroimaging still to in a single patient to establish the risk of cognitive impairment. What we use, or what you search, is how some profiles of cognitive impairment may predict dementia, and this is very important because in the coming studies of drug trials for cognitive impairment, we have to select very carefully our samples, and these are the new criteria of the task force criteria of the MDS, and they requires 2 levels, and the second one requires 2 tests for 5 domains, and to have at least 1 test in 2 domains that is altered, or 2 tests in a single domain. That is, the question is whether it is useful to define a risk sample or risk group of patients, but I'm going to show some different examples that show that perhaps this is not very practical, at least such as nowadays. For instance, this study showed that there were a predominant among patients with mild cognitive impairment, a predominance of multi-domain cognitive impairment. That is, it's difficult to define single domains, and some factors are overlapped in many clusters. And for instance, these papers, the analysis factor yielded 7 factors. This is another one from Italy, difficulty on defining subtypes of risk, because most mild cognitive impairment patients show multiple domains. And Besides this, there were in this study 2 converters from mild cognitive impairment to dementia, but 9 reverters from mild cognitive impairment to normal cognition. And perhaps this is due to different definitions of whether we accept an abnormality in the test in 1.5 standard deviation, 2 standard deviation, 1 standard deviation. But the fact is that even if you work properly and very carefully, most of the patients have this multiple domain, and it is not easy to define. This is a very recent paper also, and they say, okay, subtyping perhaps is not so useful, and cognitive change is continuous rather than dichotomous, and it is not easy to separate these patients. And perhaps this can say that besides using for the next cognitive trials test according to the MCI criteria that everyone uses a different one, perhaps cognitive scales that are global may be more useful. But these instruments have different sensibilities and specificities. I'm not going to enter on these, but these are recommended instruments, and you can see that the specificity for mild cognitive impairment of these instruments is not very good. This is our experience. We have recently examined our sample of more than 100 patients with less than 5 years of evolution, and this is the pie showing that mild cognitive impairment is also multi-domain and heterogeneous, and it is difficult to classify them, but if we use the Parkinson's disease cognitive rating scale, we can classify with a very good specificity and sensibility. Just to go to an end of this, another way that to classify patients is by their functional impairment in everyday life. And of course, the distinctions between dementia and mild cognitive impairment requires functional everyday life activities to be impaired, but there are no specific instruments to do this, and of course, among the recommendations of the task force, there are no specific instruments. This is one, Parkinson's disease cognitive functional scale. It's very easy to use, 5 minutes or less. And it has maximum accuracy for detecting functional impairment, not only between normal cognition and dementia, but between dementia and mild cognitive impairment, because these patients also have problems. Another newcomer is the Penn Parkinson's Daily Activities Questionnaire. This is also by the group of Dan Weintraub, a very nice developed scale. Very good clinimetric testing. I'm not going to enter into these, but the main limitation from my point of view is that there are no reported values for discrimination between normal cognition and mild cognitive impairment. Then, of course, it is very easy to determine when a demented patient have functional problems. What we do once we say, okay, this patient has cognitive impairment, then the only accepted treatment, at least in Europe, is to use rivastigmine in this patient, and there is a lot of evidence that this can be useful. Not so for memantine, are not so good, but are still used. Other attempts to use other drugs, such as rasagiline, for instance. This is a very study with many tests, and they also showed that rasagiline improves attention, but not cognition. And there is a recent study of mild cognitive impairment patients with rivastigmine. Why not if it runs in dementia? Why not if patients from the very beginning have cholinergic deficits? But this study was not positive, and from my point of view, perhaps this was due to use not the very good instruments to measure cognitive impairment in Parkinson's disease. They used the ADAS-Cog, that is an Alzheimer's disease instrument. Then this is a work in progress, and to demonstrate clinical benefit in an efficacy trial of treating mild cognitive impairment, we need to make an adequate selection of patients, perhaps not only based on cognitive performance, but on cognitive performance and some subgroups of patients, what is called enriched samples. We have to use adequate instruments, and it is important to use a functional instrument as a co-primary measure. In the meantime, when we still not have drugs, we can improve functional disability in patients with cognitive rehabilitation, cognitive training, and you can use commercially available games, maybe as effective and less costly than a personal trainer, but I'm not against this. And if you want your patients to have a nice day, you can send them to dance tango, because it has shown that it is good for mocha and also for other items in the everyday life of the patients. Then, to conclude, cognitive impairment has an heterogeneous basis in Parkinson's disease. There is a frontostriatal dopaminergic dysfunction and a posterior cortical pathology added with cholinergic deficits. These deficits are not only additive but synergistic, and trials that have been made since today have been hampered perhaps by inadequate, poor designs, and we need better designs and new drugs to test our patients. Of course, disease modification is the ultimate goal for preventing cognitive decline in Parkinson's disease, but we are expecting for anti-synuclein agents, for anti-Alzheimer's agents, also for anti-neuroinflammation or vascular modifiers, and further work still is required to characterize the clinical variability of early cognitive impairment, to establish how these phenotypes relate to the existing biomarkers, and to better design cognitive studies with enhanced cognitive samples. Thank you very much for your attention.